I mean, if you put standard anesthetic cream on, like a normal patch of...
Like your forearm or something.
Yeah, exactly, like your arm, you are going to be sitting in a waiting room for, up to 2 hours before that area is even numb enough for a minor procedure.
Oh, easily 2 hours. It takes forever.
Right. But if you take that exact same cream and apply it to the anterior vaginal wall, the tissue is completely numb in like 5 minutes.
5 minutes. It's honestly wild.
It is. So today we are looking at a stack of surgical guides, pharmacological data, and clinical case studies to uncover how doctors manipulate one of the most sensitive, complex, and highly defended environments in the entire human body.
It really is a biological fortress.
It totally is. Welcome to this deep dive. Our mission today is hyper-focused on one really intricate medical question, which is, how do medical professionals completely numb the highly sensitive anterior vaginal submucosa before, a deep injection or a surgical procedure?
It's a remarkable engineering problem, biologically speaking.
Yeah.
Because we aren't dealing with a simple layer of skin here.
No, not at all.
The vaginal mucosa is a profoundly complex environment. It's densely packed with microscopic nerve endings. It's highly vascularized with blood vessels.
And it entirely lacks that tough protective outer layer of dead skin cells that covers the rest of our bodies, right?
Exactly. Whether you are a medical professional brushing up on techniques or a patient wanting to understand a future procedure or just someone who loves the mechanical brilliance of human anatomy, the sheer orchestration required to safely bypass this tissue's alarm system is just staggering.
Well, I want to dive right into the mechanics of that alarm system, starting with the surface. Because before a surgeon can repair a deep structural issue or inject a therapeutic filler, they have to get past the biological equivalent of a highly secure front door wired with a hair trigger alarm.
That's a great way to put it.
Right. To avoid the intense, sharp pain of an initial needle prick, doctors have to neutralize the surface first. Our sources highlight a specific protocol by a Dr. Lau for vaginal rejuvenation, and step 1 is actually a preemptive strike.
Right, numbing the mucosa before any needles are even brought into the room.
Exactly.
Which is an absolute necessity.
Yeah.
I mean, you cannot introduce a needle for deeper anesthesia if the patient is bracing or pulling away from the initial contact.
Because of the pain.
Yeah. So the protocol utilizes a custom compounded local anesthetic gel applied directly to the vaginal area. The entire goal is just to temporarily silence those superficial nerve endings.
And the pharmacology behind these gels is intense. The sources mention a very specific formulation that clinics use, which is lidocaine 23% paired with tetracaine 7%.
Yeah, that's a heavy hitter compound.
It is. This isn't something you pick up at a pharmacy. It's compounded specifically for this delicate tissue, often used before procedures like fractional RF microneedling.
Right. Which involves using tiny needles to deliver radio waves that heat and rejuvenate the underlying tissue.
And what's fascinating here is the deliberate pairing of those two specific drugs, lidocaine and tetracaine.
They're both local anesthetics, meaning they block pain in a specific area, but they belong to entirely different chemical families.
They have completely different timelines, right?
Exactly. Lidocaine is an amamide-type anesthetic. On a molecular level, it's relatively small and nimble. It rushes in and blocks the sodium channels in the neuronal cell membrane very quickly.
Okay, so let's unpack this a bit.
Yeah.
Blocking sodium channels. Normally, when a nerve detects pain, say the sharp point of a microneedle, it wants to send an emergency signal to the brain.
Right, an electrical impulse.
Yeah, so to do that, the nerve cell opens up little gates, letting sodium ions rush inside, which creates that impulse that shoots up the spinal cord. And the lidocaine basically acts like
a cork plugging those gates.
Exactly.
That is the exact mechanism. It physically stops the electrical impulse from ever forming. But because lidocaine is small and nimble, it can also wash out of the tissue relatively quickly.
Which is why they add the tetracaine.
Yes. Tetracaine is an ester-type local anesthetic. Its molecular structure is much bulkier, so it takes longer to navigate into position and bind to those sodium channels.
So it has a slower onset.
Right. But once it locks in, it is highly lipophilic. It loves fat, so it embeds deeply into the tissue, and the body's local enzymes take much longer to break it down.
Resulting in a much longer duration of action. You kind of get the best of both worlds. The lidocaine kicks the door down fast, and the tetracaine holds it open.
I love that analogy.
Thanks. Now, to understand how fast this happens, we have to look at the clinical trial data on another topical cream mentioned in our stack, which is EMLA.
Ah, EML, the classic.
Yeah, it's a 50-50 mixture of 2.5% lidocaine and 2.5% prilocaine. And the timeline differences between where you apply it are wild.
Oh, totally night and day.
Like I mentioned at the start, if you put EMLA on intact skin, like the keratinized, tough surface of your arm, it takes 1 to 2 hours under a sealed dressing to provide enough numbness for something like a skin graft. But on the genital mucosa, it literally takes 5 to 10 minutes.
Well, the biological terrain dictates the absorption profile. Intact skin has a layer called the stratum corneum, made of dead keratinized cells.
It acts like a hardwood floor, right?
Mm,
Liquids just beat up and sit there, absorbing incredibly slowly.
exactly. But the genital mucosa lacks that tough, dead layer. It is highly vascular, it's moist, and it's remarkably permeable.
It's essentially a highly absorbent sponge. It just drinks the medication in.
It does.
But wait, I'm getting stuck on the timeline here. Since it absorbs so fast, like a hyper-absorbent sponge, is there a risk of the medication wearing off too quickly if the doctor takes too long to start the procedure? Doesn't the rich blood supply just wash it away?
That is absolutely a biological race against the clock. The clinical data reveals that after a 5 to 10 minute application to the female genital mucosa, the average duration of effective analgesia against sharp pain is short.
How short?
They tested this using an argon laser stimulus, and it's only about 15 to 20 minutes.
Wow, that's nothing.
Right. The rapid absorption is a double-edged sword. It enters fast, but the dense network of local capillaries clears it out fast too.
So the topical compound isn't the main event. It just buys you enough time to safely administer the deeper anesthesia without causing the patient distress.
Exactly. We use the topical gel to silence the surface, but that only buys you millimeters of depth.
Mm.
The moment a surgeon needs to repair a deep structural issue like a prolapse or inject a volume of filler.
They hit a literal anatomical wall.
Right. The topical gel cannot penetrate deep enough to numb the submucosal layers or the fascia.
Which brings us to the next stage of this orchestration. The surface is numb, the needle can safely enter the tissue. But how do doctors inject an anesthetic into the incredibly thin submucosal layer without accidentally punching straight through the vaginal wall?
Or worse, hitting the organs right behind it.
Right, like the bladder or the rectum.
So we have to transition from pharmacology to physical mechanics.
Right.
When surgeons perform procedures like midurethral slings or when they repair a rectus.
Which is a bulging of the rectum into the vagina, just for context.
Yes, exactly. They employ a mechanical technique called hydrodissection.
Hydrodissection, using fluid to dissect or separate tissues.
Right. The physician uses a needle to inject a volume of fluid directly beneath the vaginal epithelium. This fluid is usually a local anesthetic, like 0.5% to 1% lidocaine or bupivacaine.
Or ropivacaine, the sources mentioned.
Yes, and crucially, it is mixed with a tiny, heavily diluted amount of epinephrine.
Right, and I think here's where it gets really interesting. Because they aren't just injecting this fluid to numb the deeper tissue, the fluid itself is a physical tool.
It absolutely is.
Imagine trying to peel a really stubborn, fragile paper sticker off a piece of glass. If you just take a razor blade and try to scrape it off dry, you're almost guaranteed to scratch the glass or tear the paper into a million pieces.
Oh, for sure, it's a mess.
But if you take a syringe and inject a thin layer of water completely underneath the sticker, the water balloons up, lifting the paper away from the glass seamlessly.
That captures the physics perfectly. By injecting the fluid under pressure, the surgeon physically separates the anterior vaginal wall from the underlying structures, like the bladder neck.
So the fluid balloons the tissue apart.
Exactly, creating what surgical guides call a tensioned artificial surface. It creates a safe, fluid-filled buffer zone. This makes it dramatically easier for the surgeon to dissect the appropriate tissue plane safely.
Without any risk of cutting into adjacent organs. But let me pause and ask about the patient's experience here.
Okay.
If a doctor is forcefully injecting fluid into this incredibly tight space, physically stretching and pushing the tissues apart, doesn't the pressure of the fluid itself cause pain? Or does the lidocaine work instantly as it enters?
The lidocaine works virtually instantly upon contact. Because the surface was already numbed by the topical gel, the needle slipping through the mucosa is painless.
Okay, that makes sense.
And as the fluid forcibly pushes the deep tissue planes apart, the local anesthetic within that fluid is immediately bathing the freshly exposed nerve fibers, shutting down their sodium channels before they can fully register the stretch as pain.
Wow. And you mentioned earlier they mix epinephrine into that fluid.
Yes, epinephrine is the linchpin of this technique. It acts as a powerful vasoconstrictor, meaning it forces the local blood vessels to shrink and clamp down.
which solves two massive problems simultaneously. First, it controls bleeding, right?
Exactly. By shrinking the blood vessels, it significantly reduces bleeding during the surgical dissection, giving the surgeon a perfectly clear view of the anatomy.
And second, going back to our race against the clock problem, if you constrict the blood vessels, you stop the body's circulatory system from quickly washing the lidocaine away.
Right. It traps the numbing agent exactly where it's needed. It turns a 20-minute window into a multi-hour window, providing profound, localized anesthesia for the duration of a complex surgery.
It's an incredibly elegant biological hack, and we see this exact same demand for precision in non-surgical injection treatments as well.
Oh, absolutely.
Our sources included a fascinating case report detailing a 48-year-old perimenopausal woman being treated for vulvovaginal atrophy. To give some context, this occurs when estrogen levels drop, causing the vaginal tissues to lose elasticity, lose hydration.
Become significantly thinner and highly sensitive.
Exactly. And to restore the health of that tissue, specialists are increasingly using a multi-layer hyaluronic acid, or HA, approach.
The case study is a masterclass in tissue navigation. They use different formulations of HA based on the depth of the injection.
Right. Deep down, they use HA cross-linked with a compound called PDE, which essentially acts like microscopic scaffolding to structurally support the tissue.
And closer to the surface, they use non-cross-linked HA, which acts like a sponge to draw in moisture and restore hydration.
But the delivery method is what caught my attention. They don't just jab a sharp needle into this highly sensitive, atrophied tissue.
No, definitely not.
According to the report, they first inject a tiny amount of lidocaine into the subcutaneous tissue. Then they use a sharp 16-gauge needle for one purpose only, to make a tiny entry hole in the skin.
They don't actually inject the filler with it.
Right. They immediately pull the sharp needle out and switch to an 18-gauge cannula.
A cannula fundamentally changes how you move through the body, unlike a needle, which is sharp and slices through whatever's in front of it.
Including nerves and blood vessels.
Exactly. A cannula has a blunt, rounded tip. So they slide this blunt cannula into the pre-made entry hole.
And because it's blunt, as they push it through the tissues, it gently pushes blood vessels and nerves out of the way rather than slicing through them. This drastically reduces bruising and pain.
It's so much safer.
And then they use what they call a retrograde fan technique. They push the cannula all the way in, and as they slowly pull it back out retrograde, they inject the HA scaffolding, fanning it out to distribute it evenly.
And the precision required for the anterior vaginal wall is even more extreme. The report details targeted microinjections of 0.1 ml volumes into specific anatomical coordinates.
To put that in perspective, 0.1 milliliters is roughly 2 drops of liquid.
Just microdroplets. They are targeting highly specific areas, such as the distal anterior vaginal wall, the region commonly referred to as the G-spot, located approximately 1.5 centimeters from the urethral meatus.
Which is the external opening of the urethra.
Right. When you are injecting microdroplets into an area measured in millimeters, absolute patient stillness is non-negotiable. Any flinching could result in placing the filler into the wrong plane or accidentally injecting it into the urethra itself.
Yikes. So that stillness relies entirely on the foundational layer of topical and local anesthesia functioning perfectly.
Perfectly.
It really is a delicate millimeter by millimeter negotiation with the nervous system. You start with the topical gel to silence the surface, you move to the local injection to numb the deeper tissue, and you use hydrodissection to physically balloon a safe path.
Right.
But what happens when that still isn't enough?
When you need more coverage.
Exactly. For deeper, highly invasive obstetric or reconstructive procedures, when doctors need to completely shut down sensation in the entire pelvic floor, they bypass the local tissue entirely. They stop trying to unplug individual alarms and go straight to the main power line.
Right, they target the pudendal nerve.
The ultimate numb. Our sources outline the anatomy and the procedure for a pudendal nerve block in vivid detail. The pudendal nerve is a major somatic nerve that arises deep in the pelvis from the sacral plexus, specifically branching off the S2, S3, and S4 spinal nerve roots.
It's the primary electrical cable supplying sensation to the perineum, the external genitalia, and the surrounding muscular structures.
So if you can successfully block the pudendal nerve, you block everything downstream of it.
Exactly. And there are a few different anatomical routes a physician can take to reach this nerve.
Yeah.
They can go through the perineum or near the rectum, but for gynecological procedures, the transvaginal approach is the gold standard.
I mean, if you were listening to this and squirming a little bit at the thought of a needle searching for a nerve trunk deep inside the pelvis, you aren't alone.
Oh, it's intense.
The anatomy involved here requires immense skill. The patient is typically in the lithotomy position, lying on their back with their legs up in stirrups. The doctor literally uses their fingers inside the vagina to physically palpate the vaginal sidewalls, feeling through the tissue for a specific bony landmark called the ischial spine.
The ischial spine is the beacon in the dark. It's a small, bony prominence on the pelvis. If the physician cannot feel the bone directly, they find a thick, firm band of tissue called the sacrospinous ligament and trace it laterally until they hit the bone.
Because the pudendal nerve runs immediately behind this ligament, right next to the spine.
Right.
Now, you are dealing with a long needle inside a very delicate space. To get the needle safely to that deep ligament without tearing up the vaginal wall along the way, the surgical guide describes using a specialized needle guide called an Iowa trumpet.
The guide is paramount for protecting the patient's vaginal mucosa from accidental laceration.
It functions exactly like the inflatable bumpers they put in the gutters at a bowling alley for kids, right? You slide the needle down the hollow tube of the Iowa trumpet, and the bumper guarantees the sharp tip of the needle goes exactly where it needs to go.
Preventing it from veering off into the surrounding soft tissue, yes. Once the needle guide is firmly in place, the physician advances the needle to puncture the sacrospinous ligament.
Which hurts, I imagine.
Well, because ligaments are densely packed with pain receptors, they will often inject a small 3 ml buffer of anesthetic directly into the ligament first to minimize the sharp discomfort.
Okay, smart.
Then, they advance the needle further, pushing it about 1 centimeter caudal, meaning downward, toward the tailbone from the ischial spine.
And this is where the physician is operating entirely blind, relying solely on tactile feedback. The sources say they advance the needle until they feel a physical loss of resistance. I have to ask you to break that down. What does that tactile pop actually feel like for a surgeon, and how do they know they haven't gone too far?
It is a highly distinct tactile pop that reverberates through the needle into the physician's hand. Think about the anatomy. The sacrospinous ligament is an incredibly dense, tough, fibrous band of connective tissue.
So there's a lot of pushback.
Right. As the needle moves through it, the doctor feels firm, heavy resistance against the pressure they are applying to the syringe. But immediately behind that dense ligament is a pocket of loose, fatty areolar tissue. And that pocket is exactly where the pudendal nerve sits.
So they're pushing hard against a wall, and suddenly the wall just gives way.
Exactly. When the needle tip clears the dense ligament and enters that loose pocket of fat, the physical resistance vanishes instantly. It feels very similar to popping a piece of thick, heavy-duty bubble wrap. The tension dropped to zero. That tactile feedback is the signal that the needle tip is exactly where it needs to be.
So they feel that pop, they stop advancing the needle, and they immediately inject the heavy dose of anesthetic, right?
Well, this raises an important question regarding safety, because injecting immediately could be fatal.
Wait, really?
Yes. They are now sitting right next to the pudendal nerve. But major nerves do not travel alone. They are almost always accompanied by major blood vessels. In this exact location, the pudendal nerve is immediately adjacent to the inferior gluteal and pudendal blood vessels.
Oh, I see.
If the doctor were to accidentally inject 10 milliliters of concentrated local anesthetic directly into an artery or a vein, the medication would shoot straight into the bloodstream. This causes systemic toxicity, which can lead to seizures, cardiac arrhythmias, and cardiac arrest.
The stakes are incredibly high. So how do they ensure that needle tip isn't resting inside a vein when they can't even see it?
They must perform a technique called negative aspiration. Before the doctor pushes the plunger down to inject the medication, they actually pull back on the syringe plunger first, creating a vacuum.
Checking for blood.
Right. If a flash of blood throws back up into the syringe hub, they know the needle tip has pierced a vessel. They must pull back and reposition the needle entirely.
And if there's no blood?
If they pull back and no blood returns, it confirms they are safely floating in the extravascular space next to the nerve. Only after a negative aspiration do they inject the typical 10 milliliter volume of local anesthetic.
And to make sure this elaborate blind navigation actually worked, they do a final check, a simple pinprick test in the anogenital area. If the patient feels pressure but no sharp pain, the block is successful.
And then the doctor repeats the exact same procedure on the opposite side of the pelvis to achieve a bilateral block,
shutting down sensation across the entire region.
It is a masterclass in applied anatomy. using bony landmarks, specialized protective guides, tactile feedback, and negative aspiration to safely deliver a potent blockade to a major nerve trunk. All done by feel.
So, what does this all mean? We started out this deep dive trying to figure out how doctors bypass the incredibly sensitive alarm system in the anterior vaginal submucosa.
And it's a journey.
It really is. It's a multi-stage, highly choreographed orchestration of pharmacology, physics, and anatomy. You start with custom compounded gels pairing nimble lidocaine with bulky tetracaine that absorb rapidly into the mucosal sponge to silence the surface.
Right.
Then you use hydrodissection, utilizing a fluid mixture of anesthetic and epinephrine to safely balloon the tissues apart, separating delicate layers without cutting while clamping down on the blood vessels to trap the numbing agent.
And finally, when the procedure requires profound anesthesia, you bypass the local tissue entirely. You utilize tools like the Iowa trumpet and the tactile pop of the sacrospinous ligament to deliver a targeted pudendal nerve block.
Shutting down the main electrical cable before the signals can ever reach the brain. It is truly staggering to realize that this intricate dance of chemistry and anatomy is happening behind the scenes in countless outpatient clinics and operating rooms every single day.
It really is.
All of this innovation, all of these highly specific tools and techniques are fundamentally designed around protecting patient comfort and safety.
Yeah, and I mean, if we connect this to the bigger picture, there's a specific detail in our sources that hints at where pain management could be going in the future.
Right, the stem cell study.
Yes. We had a source detailing a study involving stem cells and pelvic floor denervation in rats. Essentially, they were studying nerve injury in the pelvic region.
Tracking the biological fallout of physical trauma to the pudendal nerve.
Exactly. To do that, the researchers were tracking a specific biological marker called UCHL. UCHL is a protein widely distributed in nerve cell bodies and nerve axons. It essentially lights up where the nerves are. What they found was that after the pelvic denervation injury, the actual density of these UCHL nerve fiber markers in the anterior vaginal wall significantly decreased. The nerves physically retreated, and this diminished state lasted for months.
So physical trauma literally caused the local nerve fibers in the mucosa to temporarily diminish in number.
Which raises a profound question about the future of surgery. Currently, our entire approach to pain management involves shouting over the alarm system. We use lidocaine to forcefully block the sodium channels, or we inject fluid to stretch the tissue, or we flood the main nerve trunk with anesthetics.
We're just putting earmuffs on the brain.
Right. But if physical trauma can cause the actual density of nerve fibers in the anterior vaginal wall to biologically decrease, could we eventually harness that mechanism intentionally?
You mean instead of just masking the alarm signals, actually temporarily removing the biological sensors themselves?
Could we eventually see localized biological treatments, perhaps targeted stem cell applications or advanced topical therapies applied a week before surgery that safely and temporarily command the nerves to retreat?
A treatment that physically turns down the density of nerve fibers in the mucosa.
Exactly, eliminating the need to carefully navigate around them with blunt cannulas and complex nerve blocks.
That is a fascinating possibility for you to mull over as we wrap up. The idea that one day we might not need to carefully diffuse the biological alarm system by plugging up sodium channels and ballooning tissue with fluid.
And we might just tell the nerves to take a break.
Exactly. Biologically ask the nerve endings to step aside for a few days while the surgeons do their work. Until then, we rely on the incredible millimeter by millimeter precision of the compounded gels, the blunt cannulas, and the tactile feedback of the Iowa trumpet.